Now we're going to finish up the second part of Chapter 51. This part is going to cover amputations, complex regional pain syndrome, knee injuries, carpal tunnel, tendinopathy and joint dislocations, sprains and strains, rotator cuff injury, and most of this should sound familiar from in the past. So let's just start with amputations. It begins on the very bottom of 1069 into 1070. They can be surgical, traumatic. There's various levels of amputation, and of course the complications are hemorrhage, infection, phantom limb pain, neuroma, and flexion contractures. This is a copy of the picture that's actually in your text on multiple places. And note here, because I've seen this a few places, a signed amputation is like in the middle of the foot, a mid-foot amputation, which if they can, they try to do that so that you don't need a prosthesis. They do their best to do a below the knee. That also helps with prosthesis if they can, and keep as much as they can here. Here's just a picture on amputation, on bringing it and cutting the nerves, and just what's involved with amputation. As your text says, loss of the great toe is significant because it affects their balance. And sign amputation, here it is one of the places that it addresses it being due to peripheral vascular disease of being in the middle of the foot if they can do that. They want to keep below the knee if possible. Sometimes they have to go all the way up and do a hip disarticulation to pull it out and remove the hip joint and possibly into the pelvis. Sometimes that'll be when there's a mass or cancer, maybe just a horrible traumatic crush injury or something like that. And the complications, which I mentioned, your text lists on page 1071. Note here, there's a cultural consideration. The incidence of lower extremity amputation is greater in the Black and Hispanic populations because the incidence of major diseases leading to amputation, such as diabetes and arteriosclerosis, is greater in these populations. Number 2, any amputation, traumatic or surgical, they have to cut through a major blood vessel. So traumatic, there is a great risk of hypovolemic shock, also a great risk of infection getting into the bone, osteomyelitis, major infection. MRSA, methicillin-resistant staph, is a biggie to getting into osteomyelitis into the bone. And let's see here. Here's the thing. Your text, I think, mentions a little about wrapping. This is just a really good picture on the different techniques for wrapping and always keeping it a figure 8. Care of the patient with an amputation, assessing the skin for breakdown, washing, rinsing, and drying the stump daily. Do not apply anything to the stump like alcohol that will dry it off. And you want it to get tough, but you don't want it dry, so you're not doing lotion to soften it. They do have certain wrappings that you're doing with it, and like a stump shrinker, getting it ready for prosthesis. They try to get the prosthesis on as rapidly as possible. Nursing interventions prevent further loss of circulation, promoting comfort. You want to make sure that they don't get a contracture in the hip where it becomes flexed forward. If the patient is able to, you want to try to put them in a prone position for an hour or so if there's no other risks why they are. And if they have to stay supine, then for them to push the stump toward the bed to prevent that contracture, flexion contracture here. This elevating the stump, that's debatable. It depends on what that surgeon wants. Sometimes they want to elevate it the first 24 to 48 hours. Some surgeons do not. That's a controversial thing there. There's no clear which is best. Phantom pain is very, very true pain. It differs from surgical pain, but it is real pain. PLP is another term for this phantom limb pain, more common in patients who have had chronic limb pain prior to the surgery. It's less common if it's a traumatic injury that has led to a sudden amputation. The phantom limb pain, they have numbness and tingling, which is referred to as phantom limb sensation and pain. The pain can be triggered by touching the residual limb, changes in temperature. It can be when they're sick, anxious, stressed. And sometimes just routine activities can trigger this pain from coming on. The pain is treated differently because the opioids will not help with this type of pain. So it is treated usually with like things that are used for nerve pain, Lyrica and gabapentin, I'm sorry, got to give you the generic names, gabapentin and pregabalin, which is Lyrica. Also, beta blockers, the ones that end in law, like propranolol, are used on a chronic basis to try to stop some of that burning sensation. Antispasmodics such as baclofen, which is usually used for people with muscular dystrophy or people with spastic muscular things. So baclofen can be used for these patients, and baclofen is the generic name. They can have spasms and cramping. Sometimes antidepressants are helpful for this pain management. Also physical therapy, heat massage, sometimes TENS units, ultrasound therapy. Usually it's multifaceted management for the phantom limb pain. They can develop a neuroma, which is a sensitive tumor that forms in the damaged nerves. They usually do not remove it because neuromas tend to grow back. I mentioned flexion, contraction, lots of things for emotional, psychosocial, dealing with the family is all covered here in your neurovascular checks. Just look through your text. And not see that done. It talks about doing an ankle brachial index on a stump. I've never done that. Traumatic emergency care, traumatic amputation. It talks here about a finger amputation, to put it not directly in the water or the ice, put it in a baggie and then put that into the water or the ice and send it with the patient. Primary factors to monitor signs indicating that there is insufficient tissue perfusion and hemorrhage, looking at your skin flap, looking for the color of the skin, looking for changes in your pain distinguish routine, surgical pain, compartment syndrome type of pain versus your phantom limb pain. Preventing infection, broad spectrum antibiotics, inspecting the incision site. For a mattress, it talks about positioning. I think I covered all this about your wrapping, lifestyle changes. Oh, it has a different picture for your wrapping on page 1074. And I think that pretty much covers this section. Now we're going to go into a fairly new complex regional pain syndrome. They used to call it reflex sympathetic dystrophy. So CRPS is the new terminology. Commonly occurs in the feet and the hands, although it can occur other places. It is a triad of clinical manifestations. Abnormalities in the autonomic nervous system results in changes in color, temperature, sensitivity in the skin over the affected area. They have excessive sweating, edema. Motor symptoms can be paresis, or numbness, loss of function or weakness, muscle spasms. Their sensory perception has an intense burning. I think I have on here hypo or hyperesthesia, so they can have an increased or decreased burning sensation, increased, decreased tingling, or allodynia, where it's very, very painful. Their skin, nail changes, it's atrophying. They have swelling, edema, sweating in that area, muscle weakness, contractures, atrophy. Here's another picture that explains it. Yes, there is no cure. It's a sympathetic nervous system issue. It may or may not have a trigger. I thought this was good because it showed it in the leg versus the arm. Be familiar with this, with the arthralgia, muscle atrophy, burning pain, sweating, swelling, sensitive to touch, diffuse. They do develop osteopenia in the affected limb. The nerves are very sensitive. Tissue damage leads to hypersensitive nerves. It is sometimes they have a distinct thing that led to it. Sometimes there is none. It can be as simple as a lab draw that starts this whole syndrome. And as it says, there is no cure. This was a good thing, talking about the it's multifaceted management, trying to control this. It is a chronic neuropathic pain. Pain relievers, sometimes they use over-the-counter, such as aspirin, and different various NSAIDs may help with some of the inflammation. Usually they're prescribed stronger, like opioid medications. They, again, will use antidepressants and anticonvulsants, such as gabapentin. Amitriptyline is a common one used for an antidepressant that's used for the pain management and neuropathic pain. So they will use corticosteroids, maybe oral or injected. There is osteopenia to osteoporosis that occurs with this syndrome, so they're on things to decrease that bone calcium loss, like alendronate, which is Fosamax, or calcitonin, trying to keep the calcium in the bone. They will do sympathetic nerve blocking medications to block the pain fibers if needed. Sometimes they do intravenous ketamine, which is a very, very strong anesthetic. They might apply heat or cold to the areas when there's swelling and sweating on the limb. If the limb is very cold, they will try to apply heat, moist heats. They can use topical analgesics, lidocaine patches, physical therapy, doing gentle exercises, sometimes maybe an ultrasound or heat therapy. They can use TENS units, biofeedback, spinal cord stimulations. They can have electrodes inserted. Sometimes they do. There is nerve decompression surgery, which is a last resort. It is controversial whether it actually helps or not. They can do it through a scope or open. Sometimes they implant a neurostimulator, electrodes actually into the pain pathway. They can insert pain pump implants, even just in one area or actually intrathecally. Multiple things to try to manage the pain. It's a very difficult, and it does lead to this psychological impairment. Okay, I'm going to move on. We're going to get briefly here into these knee injuries. I gave you a good 2 pictures talking about the different cartilages, bone structure of your knee and your ligaments out here. As you read over your knee injuries, this should help you. Not that you need to memorize them, but be very familiar. Emergency care of patients with sports-related injuries, you want to read over that. Chart 51A on 1076. Here's a really good picture on common knee injuries. Understand when it says ACL, that's an anterior cruciate ligament. Understand what ligaments these are, where it will affect, what symptoms it will be, what teaching you will do to your patient. This is a good one, and your text goes into this patellofemoral pain syndrome, which is very common in runners. I know when I was a runner many years ago, we simply called it runner's knee. The pain is behind or around the patella or the kneecap. In one or both knees, it leads to usually stiffness. I don't know that I've seen swelling so much, but a lot of stiffness, usually resting, physical therapy, splinting, mild analgesics like NSAIDs. Sometimes you have a torn meniscus in the medial or the lateral that causes this clicking sound. Splinting casting may be necessary. This picture here talks about doing a meniscectomy if absolutely necessary, hopefully just a partial to scrape away or laser the torn part of the meniscus. Post-op care is like any other post-op care, checking for bleeding, neurovascular check, signs of infection, education, mobility, development of a deep vein thrombosis, following whatever mobility and weight-bearing restrictions there are. Okay, let's see. Sometimes they have to do implants for a ligament, and it briefly mentions that in your text. Okay, here into carpal tunnel. This is a very good picture of the area that it's talking about. It's actually, I've seen better pictures. I don't know if you could see here. Because you have the nerve that goes right through this carpal tunnel, and it leads to, this is your distribution because it's the median nerve for your pain sensation. The two tests you do for carpal tunnel, which I'm sure you have covered in the past, this is the Fallon's maneuver. And you notice here, it's not just that you can do this position, but maintain it for 30 to 60 seconds. And it's positive Fallon's if it produces the symptoms of pain and tingling when you hold that position for 30 to 60 seconds. And here, the Tinel's sign, light, and I mean very light, because I've seen people that are positive over the irritated median nerve, because you have this carpal right there. You lightly tap that nerve and they get pins and needles down the hand, and that is a positive Tinel's sign. Another test they do is a nerve conduction, looking for this nerve compression in there. They try to manage without surgery. These are carpal tunnel syndrome exercises, and of course ergonomics on using wrist guards, placement, making stretches of your hands, especially all the students being on the computers quite often or using your phones, game systems. They're finding that it used to be in people like 30s and 40s, but a lot of younger people are getting it because of so much chronic use of our hands and repetitive stress injuries, especially with all the computer use. This is an immobilizer that a lot of people wear. Usually they will wear it at night. Sometimes they need it during the day, but the nighttime is when symptoms are worse. The symptoms are numbness, tingling, pain in the hand that may extend up to the arm. They have a clumsiness or weakness of the affected hand. The skin is dry and may be swollen. They have color changes. Symptoms get worse over time. The pain is worse if they sustain a position in the hand or arm, as you noticed with the Fallon's. And shaking the hand temporarily resolves the symptoms. The pain is worse at night, which interferes with sleep. Surgical repair, they can do open or they can do endoscopic. They have not found that one over the other is more effective, but it's interesting that the endoscopic pain is worse than the open procedure, post-procedural, but they have equal results after surgery. And of course, I think with this, there's a higher chance of infection, and they do find that surgery is very helpful. But sometimes people that have this, the younger they are, they have to have the surgery multiple times. Some things that put people at risk for this are different connective tissue diseases, especially rheumatoid arthritis. And then they say there is a slight familial tendency possible. Okay. So now your text just goes right into, on page 1079, tendinopathy and joint dislocation. It just does a little rough couple of paragraphs, not specifically into too much. It mentions the Achilles, so I did go into the Achilles tendon problems here, as in any tendon. This was a good one. To show tendinitis is that inflammation. It can lead to a rupture. And then a stenosis or stenotic hardening of the tendon there. That's in any area where the tendinitis can progress. If it is beyond repair, they can do a tendon transplant or tendon reconstruction. And if you tear a tendon, of course, there is a chance of dislocating that joint. I found this on heat or ice. I just thought it was a really good tool on when to use heat, when to use ice. So RICE treatment, rest, ice, compress, elevate. You do that with tendinopathy. You also do that with strains and sprains. Remember, with your strains and sprains, your strain has the T in it, so that is your tendon or your muscle. Your sprain is your ligament. So strain has a T, so it is a tendon or a muscle, and sprain is a ligament injury. They can both be in different degrees. Rest, ice, compress, elevate is the initial for any of them. I thought this was good in remembering when you are wrapping anything to make sure that you're checking your neurovascular checks, that it is not too tight. Dislocated joints, which it just, I think, has one paragraph in here. It's accompanied by numbness or tingling at the joint or beyond it. Intensely painful, especially if you try to use the joint and put weight on it. Limited in movement, swollen or bruised. It may be visibly out of place, discolored, decreased or no mobility. It can be some mobility, just keep that in mind if it's not completely misplaced. Partially dislocated or subluxed. They usually will do a closed reduction to put it back in place. They may put an immobilizer or something on it to keep it so that it can heal and not go right out of place again. Then your text goes in the strain or sprain, which I mentioned, and then rotator cuff injury. And again, this is just briefly mentioned in your text. I found this picture, thought was very helpful, showing your bursa, because sometimes people get bursitis. This is inflamed and pressing on your tendons in your rotator cuff. Your rotator cuff is a group of muscles and tendons that surround the shoulder joint. Keeps the head of your upper arm bone firmly within the shallow socket of the shoulder. A rotator cuff injury can cause a dull ache in the shoulder, which often worsens when you try to sleep on the involved side. Usually you can put your finger right on the area of pain that you press in there. There's, for causes. This was a good picture in the older population. It's after a fall or just years of degeneration. They, as you can see here, immobilizing it and allowing it to heal. And then younger people, usually acute tears due to sport injury or ATV injuries. And treatment, they start with physical therapy, NSAIDs, gentle exercises. They may have to go in and do surgery, laparoscopic, oh my God, endoscopically is preferable to get in and do a repair, or sometimes cleaning up those injuries. And that is actually, I told you this was not a bad chapter. That is the end of this chapter.